Welcome back everyone to another Journal Club with Hirad at Hirad EP YouTube channel. Today we're going to review the consensus guideline about how to monitor arrhythmia after stroke, and this was based on the consensus that just published at Journal of American College of Cardiology. So this is the publication, and to start to talk about how to monitor arrhythmia after stroke, we need to go over a few important definitions. So what is cryptogenic stroke? So cryptogenic stroke is any type of ischemic stroke without an identified etiology, despite thorough diagnostic assessment. So you do all sorts of imaging, evaluating with a Holter, and all sorts of monitoring, and you don't find anything that can explain the ischemic stroke. That's called cryptogenic stroke, which is about 40% of the stroke that we face these days. Now, there is another category, there's another name called embolic stroke of undetermined source, ESUS. So ESUS is image-confirmed non-lacunar cryptogenic ischemic stroke without proximal arterial stenosis or cardioembolic source. So if you have something that is embolic and cryptogenic, we call it ESUS. About 50% of the cryptogenic stroke patients have embolic stroke of undetermined source, which is around 17 to 20% of all the ischemic strokes. Now, it's very important to identify arrhythmia as a cause, especially atrial fibrillation or atrial flutter, because multiple randomized trials suggest that if you have cryptogenic embolic stroke, but there's no atrial fibrillation, the best way to manage these patients is only antiplatelet medication. But if there is ischemic stroke that is attributed to atrial fibrillation, you will get a very debilitating and recurrent stroke, approximately 4 to 5% per year. So it's very important to identify atrial fibrillation because can be prevented. Stroke happens is more recurrent, and you can prevent it with anticoagulation. Now, these are the pathway summary for cryptogenic stroke. Of course, you do the, first thing is a multidisciplinary workup. Then you determine of the most likely stroke. Is it a high-risk cardiac embolic? If you see atrial fibrillation, if there's a large vessel disease, small vessel disease, other rare causes, or you don't know what is the cause. In that case, we call it cryptogenic or unclear stroke origin. And then you go through the management of the antiplatelet, and you consider workup for arrhythmia. So we're going to go over the pathway in more details later on. But first, let's talk. All right, so how are we going to detect atrial fibrillation? Of course, the simple way is EKG, but not always the patient is in atrial fibrillation and also needs longer-term monitoring to identify atrial fibrillation. So then we use cardiac monitoring, and as you know, cardiac monitorings are basically down to 3 categories. One is consumer monitors like an Apple Watch, like a Fitbit or Cardiac Mobile. So one of these categories. And the second one is a wearable monitors. We're going to explain in the second slide. And finally, the one that you implant is a minor surgery implantable monitors to identify if the patient have atrial fibrillation, and that atrial fibrillation can explain the stroke. The consumer monitors are playing an increasing role in health management these days. Smartwatch, chest strap, rings, medical earbuds, smart clothing even. And they basically use 2 methods of identification. One is photoplethysmography, which is based on optical technique, reading of the heart rate and rhythm. And the second one is the usual EKG base. The problem that we have is you need a skin contact all the time. The monitors are not continuous; they're intermittent. The batteries, the devices need to be charged. Also, they are not able to get your rhythm at all sorts of heart rates. They are very prone to artifacts, usually at risk. You can get these rhythm strips. And overall, it has a low sensitivity and a specificity. Although studies are pending to evaluate this to make it better, use AI. So the future is bright. We might get a better consumer monitors. And as you see here, Apple Watch use PPG and EKG both, but EKG is spot check, so you basically need the person to check it actively, and it's not going to do EKG passively or um, automatically. PPGs can be done passively and is intermittent, it's not constant. So that's about consumer monitors. So I'm going to go to the next slide. I'm going to talk about the and now down to wearable monitors. These are basically down to two categories. One is MCOT or real-time data, and another one called some sort of e-patch. You can do usually up to 30 days, but at most of the companies, usually 14 days to 21 days. They have two electrodes or more than that, but usually most of them has at least two electrodes. As you see here, we have a different types of companies. Actually, the Body Guardian, it was used to be Preventis, and then you have Philips that used to be Biotel, and then we have Zeo AT, which is a kind of MCOT type of thing, and Zeo XT, and they have 2 or 3 integrated electrodes, and then you can see all the information here that how many days they can do continuous monitoring, is it reusable or single use. So all the information is here. Multiple trials showed at least 14 days of monitoring has better utility for AFib diagnosis than 24-48 hours. So basically, a longer duration of monitoring will give you a better chance of identification of atrial fibrillation. And finally, we're going to talk about implantable cardiac rhythm monitors. And as you see, we have 4 companies. Basically, Medtronic was a pioneer, with the Link, and the Boston Scientific with the Lux, Abbott with different types of loop recorders, and finally Biotronic with the latest Biomonitor 3. They all have many years of battery, between 3 to 5.5 years. Their detection yield is very good. At 1 year, they can diagnose up to 12 to 16% of atrial fibrillation, and then up 2 years or 3 years, this goes around 23 to 28%. They have high false positive, because of noise, because of PAC, because of PVC, but recently with the better programming, with the AI help, we have a better sensitivity and specificity. And then one of the landmark trials that used Link was a crystal AFib that randomized patient to usual standard of care versus loop recorder, and they found loop recorder significantly improve identification of atrial fibrillation. So this is very important when your monitor is done, or if you have a high-risk patient, to implant a loop recorder and get the better diagnosis for atrial fibrillation in patient with cryptogenic stroke. We're going to talk about that algorithm, which is very interesting, on the next slide. So stay tuned. And this is a very important slide, pathway with recent stroke. So I'm going to go over it step by step, and then we go over important aspects of this algorithm. So patient with recent ischemic stroke, of course, you try to determine the potential etiology. You do a HMP, of course, CAT scan, MRI, EKG, and telemetry, and you do an ultrasound of the heart echo. And then also you do head and neck imaging to identify any atherosclerosis in the arterial system. Now, you might find atrial fibrillation in the get-go, so of course you need a long-term anticoagulation as probably the cause of the high-risk, we call it high-risk cardioembolic source. And then you do cardiac monitoring if you wanted to manage the patient's atrial fibrillation. Now, there are 2 categories. You still find a large vessel, small vessel disease. You start them on a long-term antiplatelet, but it also is recommended to do a cardiac monitoring and for at least 14 days and see if the patient also have atrial fibrillation, because patient with a large vessel, small vessel disease, they share same kind of risk factors that atrial fibrillation has, and they might have atrial fibrillation as well, and atrial fibrillation might play a role. So if atrial fibrillation is seen and is more than 5 minutes, you can consider addition of anticoagulation to antiplatelet regimen. The major group that we are dealing all the time is 40% of the patient. They have cryptogenic stroke. You are not yet identify arrhythmia. So you put the patient on the long-term antiplatelet regimen. Then you do a cardiac monitoring, at least 14 days. So 2 weeks of cardiac monitoring is enough. If you don't see anything on the 2 weeks cardiac monitoring, you implant the cardiac loop recorder. But in cases that have a high-risk features, you can go and implant loop recorder as initial strategy. The high-risk patient, the patient that have history of heart failure, the patient has the left atrial side that is significantly large, the cutoff are a little bit different, but is mentioned in one of the studies more than 4.1. So medium size and above left atrium will be considered as one of the features of high-risk patient. Also, there are scoring systems now for prediction of recurrence of stroke, and one of the one that had a very good C value and well validated is a Chase-Less score, which we're going to talk about it in the next slide. So if you have history of heart failure, if you have a left atrium that is large, and also you have a high Chase-Less score or other scoring system favoring high risk of recurrence of stroke, you can implant the cardiac monitor without 14 days of um, wear, um, wearable monitors. And again, if your atrial fibrillation is more than 5 minutes, you need to start the anticoagulation because this is most likely cardiac embolic source. Right, and finally, we're going to talk about these risk assessment for atrial arrhythmia post-stroke. So, as you know, atrial fibrillation has been noted in 30% of the patient with with cardiogenic stroke, in 12% of the patient with large or small vessel stroke. And there are different scoring systems were developed to identify that you have more prone to get atrial fibrillation post-stroke, to predict that you have atrial fibrillation as a cause of stroke as well. So, for example, we have a Chase-Less, which you get 1 point for coronary disease, congestive heart failure 1 point, and so on, as severity of stroke. Also, you get a negative point if you have diabetes, if you have hyperlipidemia, and prior history of stroke or TIA. Anyway, so basically these will help us to identify patient with a high risk of getting atrial fibrillation as well. So if the patient have a high risk for atrial arrhythmia post-stroke, heart failure, or we have a large left atrial size, it's better to go ahead and put a loop recorder and or monitor the patient for a longer period of time. So just want to thank you guys. This is the last slide, and please stay tuned for the next journal club. Thank you.